The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everybody, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Julie Margenthaler here to review the management of all things related to breast cancer.
Thank you. I'm happy to be here. I am the Director of Breast Surgery here at Washington University School of Medicine and Director of our Breast Fellowship.
My name is Faiz. I'm one of the fourth-year general surgery residents. Thank you, Dr. Margenthaler, for joining us today. So today we'll be talking about malignant breast disease, and that's where we'll largely focus our discussion. I was hoping for this episode to be as translatable in the clinical realm as much as possible, and so that's why I think we'll focus on a patient case and try to discuss some of the important studies and salient aspects of managing breast disease accordingly as well. So to start with, we'll plan to discuss the case of a 65-year-old postmenopausal female who comes to the surgical clinic who's been referred to our clinic with a new breast mass, which was noted by their primary care doctor. And she essentially has no other complaints at this point in time. When we see her in clinic and take her history, she reports that she's never taken OCPs before. She had her firstborn child at 22 years. She's never had any other pregnancies. She's a non-smoker, denies any substance abuse or any large alcohol use as well. And then of note, has no history of breast cancer in her family and has no other additional cancers either in her family. And then her past medical and surgical history is only notable for a lap chole that she had several years ago, which was unremarkable as well.
Okay, well, when we see patients like this who come in with a mass, we really talk about this triple assessment. And the triple assessment just means that we're going to take a very detailed but focused history that's relevant for breast cancer risk, perform a physical examination, and then we're going to involve some type of imaging, and we can talk about the details of that in a moment, and then ultimately a pathology biopsy would be warranted. So when we think about history, for instance, all of the factors you mentioned are really aimed at trying to identify risk factors that might place her at elevated risk for breast cancer. And that really boils down to family history, of course, but outside of that, we're really trying to figure out what the time frame her body has been exposed to estrogen. So for instance, if you have an early menarche or a late menopause, if it's a woman who's never had children or never breastfed, all those things result in higher rates of estrogen exposure, and so presumably could increase her risk of breast cancer. And that's really what the history is aimed at determining. Once you get into the physical exam, again, you want to do a general physical exam for just overall health, but particularly when it comes to the breast exam, we really want to do a thorough breast examination, and you want to do that in a couple of different positions. I like to start with a patient lying on their back with their arm over their head, but you also want to set them up in an upright position because sometimes you can see subtle things in different positions you might not have noticed when they're laying down. For instance, skin dimpling in an upright position may be more noticeable. And then it's also important to really focus on the regional lymph nodes. I typically do check the cervical, supraclavicular, and axillary regional areas. And then make any notes about skin changes, nipple discharge, those types of things are also relevant to the physical examination.
So that's a good segue into what we find in the rest of her clinical exam. So when we do our physical exam, she has a firm mass that's noted in the upper inner quadrant of her right breast. And then she has no axillary disease that we notice and no other lymph nodes that we find as well. So I guess from here on in, it's a good way to transition into what we would need to do for further workup and kind of get into the utility of mammography. And also I think for a lot of us, we probably want to understand the merits of ultrasonography in women who have dense breasts. And so maybe perhaps we can spend a little bit of time talking about the merits of each of those modalities.
For a patient like this, obviously we're pretty concerned about this being a malignancy just based on her age, the fact that she has a palpable mass that's new, and just your physical exam findings. So definitely we're going to do mammography, and we generally do that in a bilateral fashion because comparison is always helpful. We also would do an ultrasound in this case, not just of the mass, but also of her axillary region, because we want to understand the axillary lymph node status as well from a clinical standpoint. Here at Washington University, we do axillary ultrasound on every patient that we suspect of breast cancer. So any patient who has a BI-RADS category 4C or 5 gets an axillary ultrasound, because that can be really important in whether we consider things like neoadjuvant therapy versus upfront surgery, and also it helps stage the axilla as well. So this patient would have a bilateral diagnostic mammogram and a ultrasound of the actual mass and axillary lymph node region.
And then at the same time, obviously, we would want to biopsy the said mass as well. And this would be done with ultrasound or radiologic guidance. Is that correct?
Yes. So we really do not perform excisional biopsy at all anymore, and we really use image-guided procedures. And so one of the utilities of ultrasound is to make sure that this mass is well visualized by ultrasound, and you can easily do an ultrasound-guided biopsy. If it's not visualized by ultrasound, that's when we use stereotactic guidance, which just means using mammography to guide it. There are also situations where patients have MRIs, for instance, that identify abnormalities that we can't see on ultrasound or mammogram, and then we use MRI to guide that. But generally, any biopsy that we're doing is image-guided, and that's going to give us a lot of information about the pathology.
So this patient does undergo a corneal biopsy. What is some kinds of information that we're looking for on the results of that, and what kind of tests are we running on the tissue specimen as well, Dr. Margenthaler?
Yes, we do prefer core needle biopsy over fine needle aspirate. And the reason for the core is you can really tell the difference between in situ and invasive disease. So that's going to be the first step. We'll be able to tell the histology, whether it's ductal, lobular, or otherwise. And then most importantly, we're going to look at the biomarkers. And that really is the best method to determine whether this patient is a candidate for upfront surgery or we should consider some type of neoadjuvant treatment. So let's just presume that this patient is estrogen and progesterone strongly positive and HER2 negative. Those are the most common, and that would be a patient where we would consider upfront surgery, knowing that she's going to be a good candidate for that, versus a patient who is triple negative or HER2 positive. We'd much more likely be considering neoadjuvant chemotherapy in those patients.
Then would you also recommend genetic testing to this individual, or would that be something you would forego given that she had no history of family breast cancer?
Genetic testing has really evolved a great deal over the last even 5 years. And I will tell you that we test nearly every woman who is newly diagnosed with breast cancer. Now, the caveats to that are you have to make sure that the insurance coverage is there, although most patients will have complete coverage of genetic testing. But we now recognize that breast cancer is a cancer that is more commonly associated with genetic mutations than some other cancers, and so most women do actually qualify for that. So we would discuss it with every single patient. Certainly if they have family history of breast or other cancers such as ovarian or pancreas, we would strongly encourage it. For this patient, I would discuss it with her, but it wouldn't be something that I would strongly recommend unless she really were inclined to understand her genetic status.
We mentioned next that there would be surgical options for her as well. I know that in clinic, when we see these individuals, we have a pretty long discussion with them that are very much focused to their own particular choices and what they would like to do in terms of breast conservation therapy as well as versus a mastectomy. I think it would be a good segue at this point maybe to talk about how there's been a huge shift over several years now away from mastectomy towards like breast conservational therapy. And I thought we could also maybe bring up some of the important studies that have been shown that adjuvant radiation is combined with breast conservation therapies equivalent in terms of survival and outcomes for women.
Right. So when I see these patients in the clinic, we look at the imaging, we look at the extent of disease versus the size of their breast. And for this patient, she sounds like she would be an excellent candidate for breast conservation, meaning that she has a reasonable tumor to breast ratio. And the important thing I think to remember is that there is no survival difference between a lumpectomy with adjuvant radiation versus mastectomy. And that's based on 6 landmark clinical trials, including NSAPP, which is really our guideline for this. And we have now over 30 years of data showing that there is actually no difference. So for a patient who's eligible for breast conservation, that's generally going to be our recommendation.
And I think that it's also important, I guess, to mention over here that sometimes if women do desire breast conservation therapy but are otherwise excluded from this recommendation given the size of their tumors, then sometimes also considering neoadjuvant chemotherapy up front can help with that and translate them towards a breast conservation approach if that's what's required as well. And I think that's largely driven by some of the clinical trials that we've had in the past that was published. I think it was B18 and B27, if I remember correctly.
So yeah, neoadjuvant therapy, you're correct. So the main purpose of those trials were to make sure that there wasn't a disadvantage to doing neoadjuvant chemotherapy. And what they showed was that there was no difference in overall or disease-free survival between adjuvant or neoadjuvant therapy. Now, since those trials were done, we use a lot more neoadjuvant therapy than we used to. It used to be more for downstaging the patient. Now we use it to determine treatment recommendations. So for instance, if we have a triple negative or a HER2 positive patient that has a 2-centimeter tumor or greater and or a positive lymph node, pretty much 100% of them are going to get neoadjuvant therapy with immunotherapy because we can then tailor the adjuvant treatment based on their response to therapy. But for this patient, if she is a marginal candidate for breast conservation, then one other use of neoadjuvant therapy would be to downstage to potentially transition somebody from a mastectomy to breast conservation. For somebody, though, that has a tumor like this, we might even think about neoadjuvant endocrine therapy rather than chemotherapy because these tumors are much more responsive to that. But the overall point is that you can use neoadjuvant therapy to downstage tumors, not only for that reason, but also for ultimate personalization of their adjuvant therapy.
So we have this discussion with the patient in clinic. She's more interested in leaning towards breast conservation therapy. When you see these patients in clinic, Dr. Margenthaler, what's your approach to the axilla and talking to them about the next steps about staging that as well?
Right. So the main treatment when we have an early stage breast cancer is to clinically stage the axilla, and that's our physical exam and axillary ultrasound. But then we also pathologically stage the axilla. And traditionally, that was done with axillary lymph node dissection until the mid-90s when the major clinical trials showed that sentinel lymph node biopsy could be used in clinically node-negative patients to stage the axilla. And what that really means is that you're going to use either a blue dye or a radiocolloid tracer, or more commonly dual, both of those, to identify the first draining lymph nodes in the axilla on the ipsilateral side of the cancer. And if those lymph nodes are negative, the trials have shown that we feel very confident you do not need to go further with a complete axillary dissection. Now, what's happened since that time is it's really evolved such that from a more recent trial, the Z11 trial, we know that even if a patient has limited sentinel node disease, so 3 or fewer that are positive, you still do not need to go on to axillary dissection because the axillary recurrence rate with good adjuvant therapy is less than 1% and equivalent to those who had full dissection. And then we can even talk about Z1071, which was a trial looking at post-neoadjuvant chemotherapy patients who had a positive node before chemotherapy, converted to what appeared to be a clinically negative axilla after chemotherapy, and you can offer sentinel node with targeted removal of the biopsy node to those patients as well. Again, if the lymph nodes have converted to negative, we don't go further with axillary dissection. So I think the take-home message from axillary staging is that we've really, over the last 3 decades, started to really minimize the amount and extent of axillary dissection that we do with the same good outcomes and without compromising axillary recurrence.
Great. So then we book the patient and we plan to go to the operating room. Dr. Margenthaler, what are some considerations that you have for breast conservation therapy, specifically, I guess, before surgery and on the day of surgery as well?
when we're taking a patient to the operating room for breast conservation therapy, there are some things that you have to consider to make sure that you're successful. And what I mean by that is our goal is to get clear margins and to adequately assess the lymph node axillary region. So what that means, in this patient, she has a palpable mass. So you could do that lumpectomy with palpation guidance or with ultrasound guidance. If you have a non-palpable mass, you really have to think about localization, and there's a number of different techniques, either wire localization or what's becoming more commonly are wireless systems, which involve some type of implantable seed that uses a variety of techniques so that you can detect that intraoperatively. On the day of surgery, the patient typically will go to the nuclear medicine department for a radiocolloid injection, and again, that's one of the dual tracers we would use to identify the sentinel nodes. And then during the surgery, it's just important to have all of the equipment positioning properly. And then most importantly, anytime we do a lumpectomy, we're always going to do a specimen radiograph at the end, regardless of the method of guidance that we used during the surgery to make sure that we have adequate appearing margins on our specimen. Now, of course, that's not pathologic, so we do have to always caution the patient that there is a chance of having to go back for a re-excision if they're not microscopically clear. But that's generally the approach, is to do a specimen radiograph intraoperatively.
So we take this person to the operating room. Are there any salient points that you think about while you're doing the lumpectomy as well as the sentinel lymph node biopsy for this individual?
I think the main things are I always have the images pulled up in the operating room. So primarily mammogram images guide us generally. You want to, if you can't feel the tumor, you want to make your incision directly over the tumor in most cases, and so you have to use your localization device to determine that. Typically, we start with the sentinel node part of the procedure, and you can really get a very good idea about where the sentinel node incision should be using your radioactive colloid, because you can use the navigator or neoprobe to identify that. But in general, if you feel the edge of the pectoralis major muscle right at the edge or lower aspect of where the hairline is, that's almost always going to be about the location of the sentinel node. And so we tell patients they're going to have a small incision under the armpit, one on the breast in whichever quadrant their tumor is located. And then the dissection is really aimed at trying to achieve a negative margin around the tumor. So that depends a lot on the size of the tumor. If you have a tumor that's smaller, you may take a slightly smaller amount of normal tissue around it versus a larger tumor. But generally, the dissection is guided primarily by your imaging, and there's a little bit of experience that goes into that, kind of knowing how widely to go around those tumors.
So I guess for the benefit of our listeners, let's suppose that this person, rather than wanting breast conservation therapy, wanted to undergo a mastectomy, and we had kind of gone over that with her in the pre-op setting. Would this change anything that we would do the day off surgery? I think a lot of residents often get confused with the use of the dual tracers and how that kind of translates from breast conservation to doing a mastectomy itself.
In general, if we're doing a mastectomy, the main discussion point that we have in addition for that patient really revolves around reconstruction. And so we always have a discussion about whether the patient desires primary closure, which means a prosthetic in their bra afterwards, or if they want breast reconstruction. And that's where we involve our plastic surgery colleagues. And then we, really talk about the nuances of skin sparing versus nipple sparing. And that has to do with breast size and shape and tumor location and what we can accomplish there safely. As far as the lymph nodes are concerned, it's still very appropriate to do dual tracing with mastectomy. The only difference is generally I would take the lymph nodes out through the mastectomy cavity rather than making a separate incision. Once you take the breast off of the pectoralis major muscle, you can generally see those lymph nodes very easily through that opening. But that's really about the only difference as far as the lymph node surgery is concerned.
The next thing I was hoping to also discuss was if, let's say this person in the pre-op setting also had clinically positive nodes, and then just excluding and had undergone neoadjuvant chemotherapy as well. when she came to the operating room, or when we would bring her to the operating room rather, we would offer her a lymph node dissection as well. Maybe perhaps we could spend a little bit of time talking about that and maybe the general steps and things we think about.
Right. And as we discussed, we've really, over time, seen a decline in axillary lymph node dissection because of these landmark trials that have come out showing in select patients we can avoid that. But there are still cases where we have to do an axillary dissection primarily for bulky adenopathy, lack of response to neoadjuvant therapy, or in some cases we find that there's more extensive disease than anticipated by our preoperative imaging. So in those cases, we talk to the patient about the risks associated with axillary lymph node dissection. Primarily those include things like sensory nerve injury to the intercostobrachial nerve, seromas, and the one that patients are most concerned about is lymphedema. And so when we're doing an axillary dissection, there are some things we can do technically to reduce those risks. And the main approach is just a very careful dissection that identifies all of the major nerve and vascular structures that can be injured during the dissection. So when I'm doing an axillary dissection, I make the incision generally in the same place I would for a sentinel node biopsy, but we extend the incision slightly so we have a little more access. Once we get through the clavipectoral fascia, typically we identify the anterior surface of the latissimus dorsi muscle because that's really the lateral most extent of the dissection. And then we open the clavipectoral fascia medially and superiorly, and you can sort of bluntly dissect down to the axillary vein. And at that point, it's usually a very good idea to identify the long thoracic nerve running against the chest wall, the thoracodorsal trunk, which is going to be at the very posterior aspect of your dissection, and then the intercostobrachial nerve, which will run across the axilla, but can often be spared if you're careful in identifying it during the dissection. Once you identify all of those structures, you can really just start taking the contents, and generally we recommend doing that from superior to inferior so that you can follow the course of the thoracodorsal trunk the entire way. That is something that can vary anatomically in patients, but generally the nerve is going to innervate medially into the latissimus dorsi. So if you do that dissection from superior to inferior and watch carefully as it's entering the latissimus dorsi, you can avoid injury. And then in those patients who do have an axillary dissection, they do have a postoperative drain. So that is one big difference between that and sentinel node biopsy.
So obviously our patient does great, and then she goes home, and then we see her back in clinic. She's doing great. Anything that we would do differently from here on in for her in terms of postoperative care? Because I think the next steps would be referring her to a medical oncologist and then pursuing adjuvant hormonal therapy given her positive receptor status.
Right. So if let's say we did the lumpectomy and sentinel node in this patient, and just for purposes of this podcast, she has a 2-centimeter estrogen positive, progesterone positive, HER2 negative tumor, and her sentinel nodes were negative. So that's a favorable situation, but we still do need to determine whether this patient would benefit from chemotherapy in addition to endocrine therapy. And the best way to do that now is with a genomic test, and typically the 21 gene recurrence score is being used, and that is an NCCN recommendation and guideline. So for any tumor over 1 centimeter, we generally send a 21 gene recurrence score. If it comes back low or intermediate risk in a 65-year-old woman, there's no benefit for chemo. If it comes back high risk, then there would be a benefit for chemotherapy in the adjuvant setting. But yes, we would refer this patient to medical oncology. The 21 gene recurrence score would be discussed, and if she's low or intermediate risk, she would be placed on endocrine therapy for 5 years. And then we would also send her to our radiation oncology colleagues for adjuvant radiation. From a postoperative standpoint, these patients generally have a pretty uneventful course. Obviously, the most common complications are things like bleeding and infection, but generally can be managed in the outpatient setting. And then I typically do see patients back at the 6-month mark, and we typically get a repeat mammogram at that time as kind of a new baseline, and then monitor them yearly thereafter.
Thank you, Dr. Margenthaler, so much for being here with us today. We got through a ton of great information related to breast cancer. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of breast surgery can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.